in this mode delivers very small tidal volumes at high rate and a set mean airway pressure which provides gas exchange at low measurable pressure, thus limiting ventilator-induced lung injury. And one of the newest mode is airway pressure release ventilation. It is actually pressure control mode of ventilation with inverse ratio ventilation. That means prolonged inspiratory pressure followed by short release of the pressure for expiration. And another trial is prone ventilation. Actually, patient here is in prone position. Ventilator support is given in prone position. A significant increase in the PO2 occurs in more than half of the ARDS patients who are turned prone. And gravitational factors redistribute ventilation to the previously collapsed dorsal areas of the lungs. Another mode is extracorporeal membrane oxygenation (ECMO). It provides temporary substitute for transpulmonary respiration while severely injured lungs are allowed to rest and recover. ECCOR, extracorporeal carbon dioxide removal. And another newest mode is partial liquid ventilation. Perfluorocarbon is an inert gas, inert materials. It causes high density liquid that easily solubilize oxygen and carbon dioxide. Now the other modalities of the treatment apart from ventilatory management. Fluid management. There are aggressive attempts to reduce left atrial filling pressure with fluid restriction and diuretics, but target should be to maintain a normal or low left atrial filling pressure. It reduces pulmonary edema and prevents further detriments in the arterial oxygenation and lung compliance. To prevent hypotension and hyperperfusion of the critical organ, a central venous pressure of 6 to 12 mm of mercury or pulmonary capillary wedge pressure of 6 to 14 mm of mercury in patients with normal heart. Treatment of infection, antimicrobial therapy should be targeted to culture organism whenever possible. Broad spectrum antibiotic prophylaxis and coverage must be weighted against the potential for toxicity and selection of resistant microbial flora. Nosocomial pneumonia is very frequent in this patient of ARDS. Skillful ARA management and measures for reducing the risk of aspiration decreases the incidence of nosocomial pneumonia. And then avoiding iatrogenic complication. Iatrogenic complication during acute respiratory failure includes complication due to IV line, due to endotracheal intubation, most important is ventilator-induced lung injury, oxygen toxicity, fluid overload, tissue hyperperfusion, and the induction of the microbial overgrowth through the indiscriminate use of antimicrobial agents. All these should be avoided. Now the nutritional management. This is one of the most important management in patient of any critically ill patient. Dietary immunomodulation. It is actually a combination of the omega-3 fatty acid, glutamine, arginine and ribonucleotide. This has proved that they reduce the infection rate in the critically ill patient. And diet rich in gamma-linolenic acid, fish oil, antioxidant, which shortens the duration of mechanical ventilation and reduces organ failure. Early enteral nutrition using standard nutritional formulation serves the dual purpose of preserving the gut barrier and allowing for nutrition to be delivered without the infection risk of total parenteral nutrition. When enteral feeding is contraindicated, critically ill patients should receive parenteral nutrition. Nutrition goals should balance that metabolic demand and prevention of the nutrient deficiencies. It should also prevent to complication of delivery mode and overfeeding. And then support of the other organ system function, hemodynamic stability, acute renal failure, gastrointestinal hemorrhage, coagulation abnormalities, and neuromuscular changes. All these should be taken care of because these changes may complicate the course of these critically ill patients. Now the other pharmaceuticals interventions, glucocorticoids. There is lots of controversy regarding use of glucocorticoids. Inflammatory mediators and leukocytes are abundant in the lungs of patients with ARDS. So treatment with glucocorticoid may be done both in early and late stage of ARDS to reduce its potentially deleterious pulmonary inflammation. A course of 0.5 mg per kg of methylprednisolone every 6 hours is conducted for up to 3 weeks, followed by a fast apart. But careful search of infection focus, which is the main risk of this therapy, must be carried out throughout the course of corticosteroid therapy. Inhaled nitric oxide, it is a potent selective short-acting pulmonary vasodilator. It can be delivered directly to the pulmonary vasculature by inhalation. It causes reduction in the pulmonary vascular resistance and improved oxygenation. Exogenous surfactant replacement. Alveolar surfactant is diminished or dysfunctional in patients with ARDS due to damage of type 2 alveolar cells, and also surfactant it reduces wall stress across the alveoli, thereby reducing potential stress injury of the lungs. Antioxidants. Increasing antioxidants or oxygen-free radical scavengers play a role in alleviating endothelial injury caused by reactive oxygen species. And also scavengers interrupt parts of neutrophil-mediated inflammatory cascade. Now, clinical trial regarding all this management protocol. Evidence-based recommendation for ARDS therapy. Recommendation A means recommended therapy based on strong clinical evidence from randomized clinical trial. B means recommended therapy based on supportive but limited clinical data. C means intermediate evidence recommended only as an alternative therapy or an expert opinion. D means they are not recommended at all based on clinical evidence against efficacy of the therapy. Regarding mechanical ventilation, low tidal volume, it is recommendation A. High PEEP or open lung, it is recommendation C. Prone position C. Equipment maneuver C. High frequency ventilation and ECMO, it is D. That means not at all recommended. Minimizing left atrial filling pressure B. Glucocorticoid C. Surfactant replacement, inhaled nitric oxide, other anti-inflammatory therapy, example ketoconazole, PGI, NSAIDs, they are D. That means they are not recommended at all. Now the prognosis. Recent mortality estimates for acute respiratory distress syndrome ranges from 41 to 65%. That means it is very high. Advanced age is an important risk factor. Patients more than 75 years have a substantially increased mortality. That means 60% compared to those less than 45 years. Mortality largely attributable to the non-pulmonary causes, with sepsis and non-pulmonary organ failure accounting for more than 80% cause of death. Patients with ARDS from direct lung injury have nearly twice the mortality of those with indirect causes of lung injury. Pre-existing organ dysfunction from chronic medical illness is an important additional risk factor for increased mortality. However, recent data indicates that an early elevation in the death space may predict increased mortality from ARDS. Clinical risk factors predictive of poor outcome. Independent predictors repeatedly associated with higher mortality rate. That means severity of the illness. SAP score and Apache score high. Non-pulmonary organ dysfunction, comorbid disease, sepsis, liver dysfunction or cirrhosis, advanced age. Other independent predictors like late ARDS more than equal 48 hours after mechanical ventilation initiation or length of mechanical ventilation prior to ARDS. Organ transplantation, HIV infection, immunosuppression, active malignancy, mechanism of lung injury, barrel trauma, right ventricular dysfunction, high FiO2, PO2 by FiO2 less than 100 on day 3, dead space fraction, lower level of PEEP or no PEEP, late respiratory acidosis, chronic alcoholism. Now the functional recovery in ARDS survivor. Majority of the patients recover nearly normal lung function, usually recover their maximum lung function within 6 months. Recovery of the lung function is strongly associated with the extent of lung injury in early ARDS. There are significant rates of depression and post-traumatic stress disorder in ARDS survivor. So to conclude, both acute lung injury and acute respiratory distress syndrome can result from multitude of the disorder, with common thread being injury to the epithelial barrier of the lung alveoli. The active exudative phase is a consequence of widespread protein-rich alveolar edema. And alveolar flooding results in significant transpulmonary shunting and ventilation perfusion imbalance, causing profound hypoxemia that is refractory to supplemental oxygen. The release of inflammatory mediators into the systemic circulation amplifies the injury to both non-pulmonary organ as well as the lung itself, a process referred to as innate immunity. Because of the frequency of associated septic conditions, infectious focus must be actively treated in patients of the ARDS. And since the early 1990s, consensus statement began recommending lower tidal volume ventilation and airway pressure, allowing for permissive hypercapnia and hypoxemia. The critical findings of the NIH-LBI was 22% reduction in the mortality using lung protective strategy regardless of the clinical etiology. And when caring for the ALI-ARDS survivor, it is important to be aware of the potential for the subsequent burden of emotional and respiratory symptoms. Thank you.